Adenoid hypertrophy in children. Clinical presentation: nasal congestion with the adenoid facies, chronic or recurrent otitis media due to the proximity to the eustachian tubes, swallowing difficulties, speech anomalies, hyponasal speech, rhinorrhea, sleep disordered breathing. The otitis media also could be due to the enlargement of adenoid tissue in the mouth of the eustachian tube called Gerlach's tonsil. Edenoid facies, also known as the long face syndrome, refers to the long, open-mouthed face of children with adenoid hypertrophy. And the clinical presentation include the most common presenting symptoms of chronic mouth breathing, snoring, most dangerous feature of sleep apnea, and the characteristic facial appearance consisting of underdeveloped thin nostrils, short upper lip, prominent upper teeth, crowded teeth, narrow upper alveolus, high arch palate, and hypoplastic maxilla. The characteristic facial appearance of adenoid facies include underdeveloped thin nostrils, short upper lip, prominent upper teeth, crowded teeth, narrow upper alveolus, high arched palate, and hypoplastic maxilla. The diagnostic feature of adenoid facies are Denny's lines, horizontal creases under the lower eyelid, first described by the American physician Charles Denny. A nasal pleat, the horizontal crease just above the tip of the nose, produced by recurrent upward wiping of nasal secretions. Allergic shyness, bilateral shadows under the eyes produced by chronic venous congestion. Diagnostic features of adenoid facies: 1. Denny's lines, 2. Nasal pleat, 3. Allergic shyness. And finally, the adenoid facies can form part of Cowden's syndrome. We'll have a look at that later. Now look at this large enlarged adenoids. That's the soft palate, the palatine tonsils, epiglottis here, the aryepiglottic fold, and the tracheal column of air with the esophagus behind. Again, this is the enlarged adenoids. Enlarged adenoids present here. Pathology. Although present at birth, they are usually invisible until age of 3 to 6 months. They can grow until about 6-8 years of age and then involute through adulthood. Enlargement is pathological when they encroach on the nasopharyngeal airway, and this usually does not occur until 1 to 2 years of age. Etiology. Both inflammatory and infectious causes should be considered. Infectious causes include Haemophilus influenzae, Group A beta hemolytic streptococcus, Staphylococcus aureus, Moraxella catarrhalis, Streptococcus pneumoniae. The common infectious agents that are involved in adenoid hypertrophy. Plain radiograph. The lateral X-ray neck is the main imaging study. The size of the adenoids is less of a consideration than the degree to which they encroach on the nasopharyngeal airway. If no adenoidal tissue after 6 months of age, then one should suspect immune deficiency. If enlarged adenoids persist well after childhood, suspect lymphatic malignancy. Treatment and prognosis. The management options include wait until they spontaneously involute, surgical removal, and indications for an adenoidectomy include enlargement causing nasal airway obstruction, recurrent or persistent otitis media in children 3 to 4 years of age. It should be taken into account that treating otitis media resolves the resultant hearing impairment as well. And finally, recurrent or chronic sinusitis. Here we see an enlarged adenoid about 2.2 or 22 millimeters large. Look at the dimensions, nearly 22 millimeters large, occupying almost entirely the nasopharynx. The posterior nasopharynx soft tissue thickening of 22 millimeters posteriorly, indenting and narrowing the nasopharyngeal air column. Soft tissue shadow of the epiglottis being normal. The tracheal air column is normal. Cervical spine and prevertebral soft tissue shadow appear normal. The findings of adenoid hypertrophy. Here we have an in-depth review of adenoid enlargement.